Okay, I think I admitted everyone. Okay, welcome to the SIG session, workforce SIG session, shortage and retention of health workforce. I think that's very annoying. I'm sorry, my video is not working well, so I turned it off, but I can continue to moderate this session. There's one important thing that the session is being recorded, and the videos or whatever the audios will be available at sometime in the future, probably about a week or so. It's time, and you can use the chat feature to put your questions, and just remind you that there will be no questions when the presenter is presenting, so they will have the full 8 minutes, and once all the presentations are over, then we'll open up for questions at the end of the fourth presentation. Thank you. Then I just introduce the first presenter, Giuseppe Moselli, and his presentation will be As Long As You Engage Me, Panel Data Evidence on Staff Engagement and Workforce Retention in English NHS. So now it's to you, Giuseppe.
Thank you, Cecile. And I'm sharing my screen. Hopefully it's going on. Yes, perfect. So this is joint work with Melissa Saili and Marco Mello, also just like me from the University of Surrey, and this has been part of a project that has been funded by the Health Foundation. Just in terms of the motivation for this work, I just would like to highlight the fact that workforce retention issues are, of course, at the foundation of the basically the sustainability of publicly funded and also private funded workforce healthcare system. So as a motivation of this work, I'm showing you some anecdotal evidence of the fact that in the latest decade, we have witnessed a decrease overall the whole distribution of retention of workers in English hospitals. And why, there are several reasons why this has happened. This is due to funding cuts and also to population aging related problems. But eventually, this is a problem that has to be reckoned with and try to be tackled. So here we ask two main questions: whether staff engagement actually has an effect on workforce retention, and whether the retention of complementary workers has an effect on workforce retention. The workhorse of our analysis is the stability index. Stability index is the leading measure for the retention of workforce in the NHS. And it is defined by this formula, basically for a given occupational group and a given hospital organization, you take 2 points in time t and time t plus tau, for example, 12 months, and you see how many workers that were originally working at time t are still working at t plus tau. This rate, interestingly, is the complement to 100 to this rate is nothing else than the sum of the churn percentage rate and the percentage rate of workers leaving the NHS for good. So what we have in mind is a model of this kind, where we have this specification of a dynamic panel data model, where our variable of interest is either stability or a measure of retention, and we measure how this is dependent on its lagged value, the engagement score, which is one of the two variables of interest that we are interested in, and the retention of the complementary group of workers. And we control for a vector of a supply, a time varying supply characteristics at hospital level. The supply side characteristics are listed here, and we include, for example, average hours worked, gender pay gap, discrimination measures, over unpaid hours per week, and the number of competitors. So what we do is estimating system GMMs a la Blunden and Board with forward orthogonal deviation, treating as endogenous these variables that are the lagged outcome, the engagement score, and the stability, the retention measure for the complementary occupation group. Let me tell you, here we mean, in terms of complementarities, we see nurses and senior doctors as complementary inputs into the hospital production function. And we treat as predetermined variables all the other variables. We also provide estimation of this other specification, very similar to specification 1, over the unconditional quantile distribution of the retention measure. And in terms of data, well, we use administrative hospital data with almost the universe of the workforce from the English NHS hospitals. And the structure of the data is such that the variable of interest, the effect of interest, so the engagement score, for example, is measured from September to November of a given year, but the retention outcome variable, so the labor market variable, is measured between September of a year T and the basically the next year, September of T+1, while all the other time varying controls are measured in the year before. Having said that, the results show that actually the engagement score for the workforce is positive and significant for nurses. This means that actually having nurses more engaged increase their retention chances within the hospital, while this doesn't happen, interestingly, for the doctors. At the same time, we find that actually the retention of complementary workers, in this case doctors, is not important for the retention of nurses because it's not significant, but instead we find a significant relationship between the retention of nurses and the retention of doctors. Similar findings affects the rate of leaving the NHS, where we find basically an increase in a positive variation in engagement decreases the chances that nurses leave the hospital, and the fact that more nurses leave the hospital increases the chances that even senior doctors leave the hospital. And these results are strongly confirmed by the specification, the unconditional quantile regression along the the distribution of the stability index. So overall, how big are these effects? Actually, these are quite sizable because, for example, in terms of nurses engagement, the importance of the effect of nurses engagement capture about 19.2% of one within standard deviation of nurses stability index, as well as basically a one standard deviation increase in nurse engagement decreases the leaving rate by about 15.5% of within standard deviation. And
1 minute left.
And similar, well, results still sizable in terms of 10% and minus 11% actually affect the related to the complementary workers retention. So it's this actually is important because it actually shows that the retention of, at least in the English NHS, the retention and the engagement of nurses is very important, not only for their own engagement and retention, but also ultimately for the retention of senior doctors. And with this, I'm done, and I will be looking for your question afterwards. Thank you.
Okay, thank you. That's perfect timing. Now it's, oops. Is Melissa Shally. Her presentation title is Stand By Me, the Impact of the NHS Improvement Retention Program on Nursing Staff Retention in English NHS. This is complementary to the previous presentation.
This is a joint work with Giuseppe Marcelli, Joe Bland, and Chris Barkey, and Marco Mello, and it's also funded by the Health Foundation. Just to give a bit of a background of our research, the National Health Service in England has been under significant pressure, particularly of nursing staff, which actually make the big chunk of the clinical workforce. Just give a bit of a context of the numbers, like what we're seeing in the NHS. The turnover of nurses has increased from 12.3% in 2012-13 to 15% in 2016-17. And we also have seen an increased number of nurses who are leaving the NHS for reasons other than retirement during this period. And there has been also a very large number of nursing vacancies. So increasing turnover compounded by nursing shortages puts additional pressure on the nurses who are already working in the NHS. This would have an impact on the quality and the continuity of care and availability of the services when nurses move from one trust to the other or quit NHS altogether. So one of the actions that can be taken to improve the nursing numbers is actually through improving retention. That will help a lot with the supply side issues that nursing staff is actually facing right now. To do that, NHS Improvement has launched a retention direct support program that we're going to be looking at in this research. The aim of this program was to improve retention of nursing staff in acute care hospitals and clinical workforce in mental health care hospitals by 2020. And now in this presentation, I'll be focusing on nursing and nursing staff, which includes nurses and midwives together. About this program, it was first launched in July 2017 with first set of cohorts, first set of trusts included in the first cohort. In total, there were 5 cohorts in this program, and each started the program at different times. So that's going to be important for empirical strategy afterwards. There was a non-random allocation of trusts into cohorts because the NHS Improvement allocated trusts into cohorts based on their past turnover rates and trends. But saying that, it is worth to emphasize that this was not a self-selection of trusts into this program. NHS Improvement has selected these trusts into cohorts. So in this paper, we're asking how effective this program has been in improving nursing retention in the English NHS hospitals. And we're answering it through a causal framework, capitalizing on the recent advances on the difference and difference methodologies. And we use monthly electronic staff records and NHS staff survey to do that. Our outcome variable and the measure of retention is, again, the stability indices that Giuseppe has also talked about. Just to briefly recap on that, it is the percentage of nurses and midwives on active assignment working in a trust between 2 periods in time. We're looking at monthly rates with 12 months difference. So the RDSP has rolled out at different times in different trusts, but this puts us actually in a multiple treatment timing setup. So if we have a close look, we can see that 5 cohorts here, they all had a decreasing retention during this period that I was talking about. And we see that there were treatments happening at different times and affecting these cohorts differently. So 2 more things before I'm moving on to the empirical strategy is that we do not expect any anticipation effect in our framework because there was a very short notice of the trust being involved in this program. And we are using the last cohort as the never treated group because of our observation window being so close to when they started treatment. So our estimation method is based on Sun and Abraham and Callaway and Santana's estimators, which are alternative to the two-way fixed effects estimator, which provides robust inference. And our estimation sample, we exclude the trusts that underwent any organizational changes or closed or opened this period of time, because we want a clear understanding of the effects of this program alone. And our evidence is based on a monthly balanced panel of 192 NHS hospitals. So moving on to the first set of results, we are interested in the dynamics of this treatment or this program. And here we see the one way to look at it is through event study plots. And here we see the dynamic treatment effect of this. Here we are comparing Callaway and Santana, Sun and Abraham, and two-way fixed effects estimators as well. What we see, the results are pretty similar for all estimators. And what we see is that the workhorse assumption of difference and difference setting is that the pre-trend parallel trends actually hold. And we see that it's holding here. And we see an overall positive impact and an increasing impact of this program on retention. Another way to look at this is to look at how each cohort has been impacted by this retention support program. And here we are aggregating the group level cohorts time average treatment effects into cohorts. So this takes into account the time that the trusts are actually spending in the program as well. So for example, for cohort 1, we see that with conditional parallel trends assumption, where we control for the number of nurses, share of nurses who experience work stress, and share of nurses, they are satisfied with their pay, alongside with the share of nurses who responded to the survey, NSS, the National Staff Survey, NHS Staff Survey. We see that the cohort 1 has reaped the most benefits in terms of improvement on their retention, nursing retention, followed by cohort 4. This is quite surprising because they spent the least amount of time in the treatment, and they had originally the highest on average retention rates. So one question is then, how big overall the retention has been improved through this program? And we can see that the overall average treatment effect was 0.76 percentage points increase and improvement in retention. But again, what does this percentage point mean? What does it translate into? This translates into actually retaining on average around 1,600 nurses and midwives who would have otherwise left their trusts. So it is quite an important effect, but it is probably not large enough to relieve the workforce pressure that NHS is currently under. This also has a policy implication, which is quite important for the sustainability of the publicly funded healthcare systems, because we show here that the non-monetary interventions such as engagement, such as employee monitoring, giving the trust the driver's seat to identify their needs and act upon them, actually works in improving retention overall. So thank you very much for your attention. I'll be welcoming questions and comments later. Thank you.
Thanks, Melissa. Now our next presenter is Edward O'Cake, and his title is "When a Doctor Falls from the Sky, the Impact of Easing Physician Supply Constraints on Mortality."
All right, thanks a lot, Cecile. And thanks to those of you who have made time to, to join in the session. So I'm going to spend the next 8 minutes summarizing the results of what I think is a really interesting and unique and policy relevant experiment. And those are big words, I know, yes. So this was an experiment that was conducted in Nigeria, and in a bit, I'll tell you a little bit more about it. But to kind of ground everyone, the question that motivated this work is, to what extent are poor health outcomes, particularly in low-income developing countries, to what extent are these poor health outcomes a result of low quality care, and specifically or in particular, low quality providers? So that's kind of the question that, that was in my mind when, when we designed the study. So very quickly, and I'll show you the design on the next slide, but very quickly, we worked, so this was conducted in participation or with the partnership of the Nigerian government. And so with their cooperation, we randomly assigned doctors to hundreds of communities across Nigeria. These doctors were posted to the public primary health center serving the community. And the postings lasted approximately 1 year. So I think this is really interesting, like I said at the beginning. One, because to my knowledge, this is the first time that doctors have been randomly assigned to communities, and certainly on, on a scale like this. And more importantly, the reason why we care is because this gives us, a way to exogenously vary the level of quality that is available to households in a community. So the assumption that is being made here is that doctors are higher quality. And when I start to share the results, we will validate that assumption. Okay, so here is the design. There were 180 primary health service areas that took part in this experiment. So think of a health service area as a catchment area. There were 3 arms in the experiment. So 60 of the clusters were randomly assigned a doctor. So the doctor was posted to the catchment area. For a second group of 60, rather than send them a doctor, we sent them a mid-level provider. So I will use that term constantly, MLP. So this is like a nurse, a midwife, a primary healthcare worker, etc. And then the third group is the pure control group. So the reason we have the doctor on the MLP arms is because we wanted to be able to credibly separate the quality effect, which is what we care about, from the quantity effect of just sending an additional health worker. So by looking and comparing the doctor arm to the MLP arm, both of these got an additional worker, but in one case, the worker was of higher quality. So that is a comparison that we'll make throughout the study. In order to make this fit into 8 minutes, I have stripped it down to its essential. So there is a lot that I will not talk about, but as many of you know now, there is a more detailed presentation available online. So in the paper, we break out because we have a lot of data. So we break out the analysis into 4 parts. And really what we're trying to do is to test. So we have sort of a causal chain in our minds, and we're trying to test each of the links in the causal chain to kind of build a coherent narrative. For the presentation, I'm going to talk about 2 and 4. So I'll be showing you the results where we look at the effect on quality, because this is, I think, really important. And then I will secondly show you the effect on health outcomes. So the first question we wanted to answer, as I said at the beginning, is, so in theory, doctors are higher quality because they receive more advanced training. So that's in theory. So one of the things we wanted to do was to validate that assumption. So at baseline, we did this extensive survey, and one of the things that we did was we measured the clinical proficiency of not just the doctors, but also the new MLPs, the mid-level providers that were posted to those communities, as well as the existing MLPs. So that is the comparison here that I'm showing you. We evaluated them on 3 different domains: medical knowledge, emergency obstetric care management, and outpatient primary care. And I'm showing you the full distributions. So these are kernel densities. The takeaway from this slide is that the doctors outperformed the mid-level providers that they replaced on every dimension that we measured. So that's the first result I want to show you. The second question then is, okay, so these doctors are more proficient. Okay, to what extent did that translate into actual quality of care? as it turns out, we measured that again pretty comprehensively. So we sent people to observe the care that was being provided in these primary healthcare centers, and we have that data. The takeaway here, so we're looking at, so these are the treatment effects. We're looking at a bunch of quality metrics, adherence to fever protocols, the likelihood of a physical exam, etc. The point here is, again, we see substantial improvements in quality. And then the final question we wanted to answer is, okay, so having shown, both of these things, how much, or to what extent did that translate into health outcomes? And the key outcome that we are measuring is newborn infant mortality. And we can talk more during the discussion about why that is. So here we are comparing each of the three arms. So we have data on more than 10,000 mothers and infants that were born over this intervention period. And we're comparing newborn mortality in each of the arms. And this is one graphic that shows you that on average, overall, you can see that newborn infant mortality went down significantly in doctor communities alone. Here is another way to show you the same result. Here, we're looking at trends over time. So the x-axis is the quarter of birth. So we're
just remind you that you have 1 minute left.
Okay. So we're looking at children born in different quarters. And the point, again, that we're trying to make here is you can see that at baseline, roughly at baseline, mortality rates were about the same. And you can see that over time, mortality, in fact, fell in the doctor communities alone. So essentially what we found was that newborn infant mortality decreased by between 6 to 8 deaths per 1,000 in doctor-assigned communities, and this represents about a 21 to 28% decrease. And to put that into context, that would effectively close the gap in mortality between rural and urban areas. And I think there are lots of interesting policy implications. But just to summarize, we found that raising levels of quality led to substantial improvements in health outcomes. For those of you who are interested in a cost benefit, we look at that in the paper, and we find that roughly each dollar spent on a program like this would return about $5 in health benefits. And again, at the end, I think we can get into this more, but I think this has lots of interesting implications for an ongoing debate in the literature about the relative effect of quantity versus quality, and a separate debate about task shifting and devolving more tasks towards mid-level healthcare providers. So yes, I will, we can talk about that more at the end. Thank you.
Hey, thank you very much, Edward. Now our final presenter, Joan Spades, registered nurse supply and demand in California during the COVID-19 pandemic.
Great, thank you. And I'm going to make sure I have a timer going for myself to help me out there. My presentation is largely descriptive at this time, but it's based on relatively new data, and I think, I hope, is of interest. So we're looking at changes in nurse education and employment during the pandemic, and then have developed a relatively straightforward forecasting model to look at what the implications might be in the long term for nursing supply and demand. We've seen a lot of headlines. These are just some from the United States. I know that there are very similar headlines that have been seen worldwide, concerned about burnout, stress, illness, et cetera, for licensed nurses who have really been on the front lines of healthcare during the pandemic. In California, we have been doing surveys of registered nurses every 2 years. California has about 12% of the entire country's nurses. So while one might say it's only one state, it's a pretty big and influential state with a GDP larger than most European countries. So we like to think that we're a nation ourselves out here. This survey has been conducted every 2 years, which gives us a really nice opportunity to look at changes over time. And the 2020 survey went out into the field with a little bit of a delay. And what I'm reporting on are the a first set of responses, nearly 2,000 California resident registered nurses who responded online. The paper survey data entry just ended, so we're about to add those into the data set. So I'll cut to the chase. The first thing that we found compared to the 2018 data is that the employment rates of licensed nurses did not really change much in the kind of the July to October period of 2020 relative to the similar time period in 2018. But when we begin to look at differences by age group, we see some really notable patterns. The first is that among younger nurses between about the age of 30 through about 55, that employment rates appear to be slightly higher than in prior years. Although these differences are not statistically significant based on the margin of error in the survey, there is a pretty clear pattern that the younger nurses maybe were employed at higher rates. Some people have raised questions about this because many nurses may also have had childcare responsibilities since many schools were closed, or most schools were closed over this time period. However, in most households in California, the nurses are either the solo income or are the largest income and earn more than spouses or partners if they are married. And of course, many of them are single. The older age groups, however, have a very notably different pattern. Among nurses who have maintained an active license, the employment rate for those in the oldest age group that we tabulate, 65 and up, usually we find about 40 or 50% of them are currently employed, and that dropped down to a third. And of the next older age group, the rate employed has been as high as 80% in some years, and that dropped down to below 2/3. We also saw a slight decrease in employment among the youngest nurses that we think is related to a lack of jobs available and greater unemployment in general. Employment settings have not changed much, so I'm just going to move on because the full PowerPoint recording are on the IHEA website. For hours worked per week, we saw about a 10% decrease in average hours worked per week. And we plan to do some more analysis because we suspect that there are some nurses whose hours were cut substantially and others who had no change. So we think the mean probably misses some important distributional changes. The only employment setting where we did not see a decline in hours relative to 2018 was skilled nursing facilities or nursing homes. But for hospitals and other settings where we saw a lot of shutdowns of clinics and reductions of surgeries that were elective surgeries, it's not surprising that the hours dropped. Nurses were asked about their plans for the next 5 years for their employment, and you don't see a lot of change for most of these different question items, except for between 2018 and 2020. You see an increase in the percentage that say they intend to leave nursing or retire within the next 5 years. But the more notable pattern can be observed when you look at the percent who plan to retire or leave nursing in the next 2 years. Among nurses 65 and up, that percentage is virtually unchanged or dropped a little. I think that nurses 65 and up who would have left in the next 2 years already left, as per that prior slide. The nurses 55 to 64 are the ones that are particularly interesting to me, in that the percent that plan to retire or quit in the next 2 years doubled relative to 2018. And there was very little change or almost no change among the younger age groups. This portends a big decrease in employment or rapid retirement of older nurses who are getting closer to retirement age and might have otherwise worked without the burnout and the stress of the pandemic. And this is a similar thing about their intentions, basically larger intention to be retired. We had open-ended responses that largely corroborate what we see in the quantitative data of the survey. A lot of comments about protective equipment, stress, safety, and so on. A few did say good things, that teamwork improved during the pandemic, nothing like stress to bring a team together. But we're doing a lot more work with these because we have another 1,000 comments that came in. So what about education? We have a survey of nursing schools in California, and we've seen decreases in new enrollments in the most recent year. Most common or almost entirely among the public colleges and universities. And the reasons were largely around the inability to get clinical placements during the pandemic. Enrollments for the future, however, are expected to bounce back. So I'll move on. So what about future supply? I have about 1 minute for this, I know. For implications for future supply, we have a stock and flow model, a very simple model, not very fancy econometrically. We found over the years that it performs about as well as a more sophisticated model. So we keep going with a simple model that's easy to update rather than something more complex that doesn't give us any better predictive power. So we have tried to build into this the various short-term impacts that I just described, as well as some of the potential longer-term impacts of retirements. So the blue line is the non-pandemic supply forecast, and the green line is the pandemic supply forecast. The line with these shorter dashes that's a little bit lower was the forecast we produced a couple of years ago. And you can see that in the short term, we're anticipating a decreased supply relative to our original projections, but then that it will bounce back and recover over time. And when we compare this to various projections of future demand, which are the blue lines, we basically find that we may be in a very significant shortage for the next few years, but that we will recover over the next 5 to 10 years. And these are the numerical estimates that we get out of that modeling approach. Again, about a 13% shortage possible over the next few years, but we're recovered pretty quickly due to the large numbers of graduations. So I will just end there.
Okay, thank you, Joanne. Now it's time for questions. You can raise your hand or put your question in the chat. Okay, maybe, yes, go ahead.
Yes, I'm happy to start with some questions. So I have a few questions for Edward. So this is really incredible. I mean, like, I really like the work. I was just wondering a little bit about the mechanism there, because I would like to know a little bit more about, for example, who these doctors are, where they are from. Are they from Nigeria or are they from another country? So basically, this is a kind of a signaling problem. Basically, I wanted to understand whether the fact that this doctor being assigned there have given a different signal of a better quality of healthcare, and basically this has, for example, has incentivized demand. I'm pretty sure that you might have those numbers, and of course you didn't have the time to present. But one thing that would be interesting to know, for example, is as in those areas where the doctors were assigned, did the demand for healthcare service increase or not? Because the idea is this is just like the quality of the doctors that has made this outcome better, or is that the fact that the doctors were there meant was reassuring for the population served by those healthcare centers, and so basically they trusted more the doctors than the midwife and nurses, and that basically generated better outcomes. And of course, related to this, there is also the point about actually how local people were informed whether there was a doctor or a nurse being assigned to the center. So I think that this is all, it's all central to understand the mechanism, whether it is just like purely the presence of the doctor, and so it's basically just the quality, or is the fact that the higher quality actually means more utilization of healthcare services, and so generate better outcomes.
Yeah.
Thanks.
Okay, no. So I think that's a great question, and something that I can speak to. So when we saw those results, I apologize. My mic is on. I can't turn it off. My children are, being noise in the background. I'm sorry. So yes, so the question about mechanism was something that that obviously I care about, and in particular the point about signaling and whether so it might be the case, and I think this is kind of what you're getting at. It might be the case that the presence of a doctor, so the doctor credential kind of is a signal of higher quality. And so that might induce people to use healthcare services or induce people to switch from one setting to the primary health center where the doctor was, etc. So again, like I said, I think that's really important. However, what we found, so when we looked at that, what we found is somewhat surprisingly, we didn't find any effects on utilization. So we look at both sort of intensive, so we look at substitution or switching from one setting to another. And then we look at, whether people are switching from home to, to formal healthcare. And in both cases, we don't really see any effects. So we don't really find any evidence that, people responded to the presence of a doctor by, either changing the pattern of utilization or being more likely to use formal healthcare. And the reason we think that is I think this speaks to your second question, which is how did people know? So we wanted it to be sort of organic, right? So we wanted to kind of mimic what an actual program would look like. So the doctor was posted there, and so the idea is that sort of organically people will find out, so households in the community will learn that there's a doctor there. What we found is that and knowing the setting, it's not terribly surprising. So there's a lot of measurement error, right? So a lot of people didn't know. So so I guess I'm saying this to explain why it's possible that we didn't see any effect on demand. So many people, or many households didn't know that there was a new doctor that had been posted to the healthcare center. Again, keep in mind that this program lasted for only about a year. So one of the caveats to the result is that if it lasts for a longer period of time, then you can sort of have the signaling effect that passes through to changes in utilization. And even when we narrowed down and look at the people who, so we looked on average, right? So for all the people in the households in our sample, we asked them, is there a doctor at the community health center? And again, like I said, we find that there were a significant number of households that didn't seem to know. But even when we look at the women who used the healthcare center, so you would expect that they would be significantly more likely to know. And yes, you see that the rate of, women saying, yes, we know that there's a doctor here increases, but still something like, and if I'm not mistaken, something like a third of women. So these are women who use services in the health center, still didn't know that there was a doctor there, right? So I think that is potentially part of so the signaling story is not really the answer here. It seems to be very much about higher quality, giving rise to better outcomes.
Thanks. So we got some questions in the chat. One from Alice to Melissa. Let's see if I can open the. Okay, so Alice has a couple of questions. You meet healthcare organizations that undergo changes, open or close. It seems that the new structured organizations might entice nurses to their local location and affect attention. Have you given thought to including measures for these?
So thank you for the question, Alyssa. I think that's a really
to these occurrences to see if they have an effect.
So these closures and the new trust opening, the closing, they are all related to these organizational changes. And the key reason that we do not include them in our analysis is because the cohort allocation done by NHS Improvement. Think about two trusts, Trust A and Trust B. One of the trusts is treated in early cohorts, and the other trust is not yet treated, but they merge together to create Trust C. So there is no way to clearly evaluate the impact of that program in that trust, because now they are merged and we don't know who is coming from where to calculate their stability indices. This is one of the key reasons for that. One thing that we could do is to keep the trusts that are still in the, that have acquired other trusts that's still there. They were there, they're still there, but it is still convolute and makes it hard to pinpoint where the effect is actually coming from. So that would be, that's why we're excluding them. And with an indicator variable, it's not really possible to account for that, particularly due to the new methodologies we're using. For example, with Callaway and Santana's approach, we calculate generalized propensity score, and we need to find a balance. And there were no other trusts in the treatments in the control group that would match with the treated trust that may have undergone organizational change. That's why we are excluding them.
And says another question for you as well. Do we measure unionization of the nurses and physicians, or are more nurses members of the union than physicians? And do you think this might make own group associations more relevant for the nurses than for physicians?
So the retention direct support program, the part we're analyzing is particularly just on nurses. So we didn't look at physicians on that front yet. We're planning to work on the clinical workforce in the mental health care hospitals. But we haven't checked for the unionization rates, but for the stability, I don't think they would, because most of the nurses, registered nurses, are already in RCN, Unite, or Unison. I don't think that would affect their retention. But I think that question may be particularly relevant to Giuseppe's presentation, perhaps, where we look at the engagement of nurses and physicians and consultants.
Well, I agree that this is a factor, but at the same time, well, we know for sure that like both nurses and physicians have some form of unionization in the UK, but in any case, the variation that we are looking at in both projects is within variation. So this is going to be factored out. And like this basically it shouldn't really affect so much, because we are looking at basically variation over time for the same hospitals. So it's you know, unless there is a big compositional changes in the members of the workforce, we shouldn't look year after year. This is not going to affect our results.
Thank you very much to both of you. Thank you.
Thank you. Just to follow up with the Giuseppe, I think one technical question. So your GMM analysis, the only within instruments you used, right? So you don't have any exogenous instrument, and these instruments are known to be quite weak, right? Did you do any kind of weak instrument hypothesis testing, or any kind of comment on the credibility of the causal conclusions you can make based on within instrument modeling?
Sure, thanks. So like it's definitely true that like there is a you know, that there are sometimes problems, but like we use actually a lot of lags for this instrument for past values that are found to be good predictors. And at the same time, like this seems to be, you know, like they basically, I haven't pinpointed those results, but they all pass both the serial correlations and the over-identification test, and with flying colors. So like we are not very concerned about this. Of course, like we might look, actually we are in the process of using perhaps even something more exogenous to adapt to, but we are pretty, you know, even because like if you see the coefficient of our analysis, actually they are not different usually from, or they are within basically the OLS and fixed effects, so they are well bounded as the theory says that they should. So in that case, we are not extremely concerned. If they were more jumpy, then it would be a problem. But in this case, doesn't seem to be. I mean, we have been checking, quite a lot, because like there are many ways to include these internal instruments that are the past values, the lags. So it's we have played a bit with that.
Yeah, I think the fixed effects will be biased, right? The dynamic panel model. I don't know how many periods you got. You don't have a really large number of periods, right?
The estimation goes over overall. It's from 2009 to 2019. So it's like
so probably So it's going to be still I think it may be small bias with FE. So I think the GNU results are also pretty close to the FE as well, right? So you're saying that so that's kind of the not really too much different from the fixed effects, right? So
I mean, like they are in the same direction. Like this is, I mean, like the point is that if you see the coefficient on the lagged outcome, actually that is just well bounded between the OLS and the fixed effect estimates, and it is just like basically this scopes exactly with basically what the theory, econometric theory, with the economic paper suggests in 1981. So that part there given that part behaves pretty well, we hope that even for the coefficient of interest, this seems to be quite okay. And the other part is that when the confirmation, if we want to look at this, is that when we look at the other non-dynamic but still a panel data model, but with basically over the distribution, we find that the effects actually is well contained within basically the quantile regression values. So that seems to be basically is an indirect confirmation that our estimates are correct for the two main effects of interest.
Okay, thanks.
Thank you.
Now, question for Joan Space from Catherine on the chart. So could the reduction in hours worked that you found be due to forced time off due to COVID-19 exposure or cases for the nurses themselves? And the second question is, was the expected supply of nursing pre-COVID already indicating a shortage compared to demand for nursing? I'm wondering if we're still in a trouble with the nursing supply, even if we recover back to the original projection in 5 to 10 years. So this would make the approximate 13% reduction over the next 5 years even more troubling. I was kind of thinking that the second one, that once the things are a bit normalized, we may be expecting some nurses maybe back to work, maybe change their mind, or maybe delay the retirement, right? Something could be possible. So whatever the predictions of the shortage you're having, that may be one of the extreme scenario. The reality would be, assuming that there is no variance of concern and the vaccines remains effective, maybe much lower shortage of these vaccines. The nurses.
Those are great questions. The reductions for hours worked easily could be forced time off due to exposure and quarantine requirements. When we were preparing the survey, it was around May 2020. And quite honestly, I had to work really hard to convince the board to even let us put in an open-ended question, just saying, how is the pandemic affecting your nursing work? The board was having a lot of other trouble, and I had to convince them that they should at least try to get some information. So I think the open-ended comments will help us answer that first question. In terms of long-term shortages, nationally, most of the analyses suggest that we are graduating about the right number of nurses in the United States to replace the baby boomers as they retire. And that's been true in California for the past 8 years or so. The problem that we hear from employers is really gets into more specific human capital, where employers are especially hospitals, are quite frankly not anticipating retirements. And so when a nurse who is retiring does so, and usually they have a lot of experience and may be somewhat specialized in working in an emergency department or in the operating room, hospitals then say, oh my gosh, I can't find a nurse with operating room experience. I have a shortage. But at the same time, we estimated that in around October, there were over 8,000 nurses in California who were looking for jobs. And about a third of those were younger nurses. So there'll be nurses looking for work, and the younger nurses, newer graduates, are having a hard time finding work and have been having a hard time for the past 6 or 7 years. But the employers are saying, oh no, but we don't want them. We only want experienced nurses. So that makes trying to, and then of course, supply and demand are, it's a dynamic system, and the data that we have tend to be static, and we don't have very good instrumental variables to try to tease out where the supply and demand differences truly are. We'll find out. Another survey will go out in early 2022, and we'll see if these are temporary changes and everybody decides to stay at work, or if there's longer term changes.
Okay, thanks. Now there's a question for Edward O'Kake from Mallory. I may have missed this, but what is the state of healthcare before the additional medical providers are added? Are there typically doctors in these clinics, or are they typically only MLPs? Also, were these doctors or MLPs dropped in through the intervention additions to the staff or replacements?
Thanks, Mallory, for the questions. And again, I apologize. In a longer presentation, I would have preempted some of these questions. So yes, so the state of the world before the intervention, nearly all of the participating, so the 180 participating communities and health centers were staffed almost entirely by mid-level providers. So in other words, there were basically no doctors working in those primary health centers. And then to the second part of your question, so they were added. So it wasn't a replacement. So this is an additional healthcare worker, and so that's why we had the 3 arms, right? So in one arm we added a doctor, but because that potentially has sort of 2 effects. It has a quality effect. You're raising quality potentially, but you're also increasing quantity. So that's why we had the MLP arm, where we added another mid-level provider similar in qualifications to the existing healthcare workers. So hopefully that answers your question, Mallory.
Yeah, thanks. I have kind of related question. I think optimal skill mix is an important issue. In the developed world, what you're trying to do is the kind of giving the task to nurses and the allied health professionals rather than physicians, right? Because that's the way we can reduce the cost and improve the access at a lower cost. In your sort of the analysis, you are kind of saying that you need to add doctors, but what is sort of the kind of, I don't know whether you had any insights into the, one doctor with how many nurses should be working and the population size, that's the kind of the, and in a developing countries, also these costs are very important, right? So you cannot actually spend too much money on healthcare. So what is sort of the kind of the optimal mix that's going to improve the access to some of those basic primary care services?
Yeah. So just to quickly comment, I think that the way that we think about the paper, the way that I think about the paper, and the way that I think about the findings of the paper. So what we show is that raising levels of quality that's available to households, or that's available to communities is going to improve health outcomes. At least that's what we find, right? And so sort of the inverse of that is that poor health outcomes are in part, at least, driven by low quality care and specifically low quality providers. So that's really kind of the question, or that's kind of the message from the paper. So we don't get into sort of what's the, to your point about what's the optimal case mix, etc.
No, I think the question here is why can't this quality care will be provided by MLPs? Why can't you? So if there's an issue here is why didn't you send doctors rather than training the MLPs or providing additional training so that they can provide better quality care?
So, and I think right there is one of the key discussion points, right? So, can you improve the quality of mid-level providers? So, we raised quality in one specific way by sending, better trained health providers to these communities. You could think about other ways of doing it, as you're pointing out, right? So you could say, so I think that's an open question. Can we raise the levels of quality of mid-level providers such that they can deliver similar levels of quality? And then I think the related question to that is, okay, if so, how? And I think both of these are open questions, right? So there's some research about providing training to healthcare providers. I think the results are mixed, right? So depending on the kind of program, you may or may not see any improvements in quality. So that is not, so those are not questions that we can speak to with this paper. We can sort of speculate about, is it possible to do this? And if so, how? But like I said, I think those are, those are open questions that remain to be answered.
Hey, thank you very much. I think we're just time now, but I believe we can still continue for if you have any additional questions for another 10 minutes or so. Anybody has any questions for any of the presenters? Or? I don't see any hands raised anywhere.
I would have one for Joan, please. John, I was really interested in this basically in the fact that a few a bunch of a significant bunch of young nurses actually were found to be unemployed. How this can happen? I mean, like given that there is population aging, I mean, this is quite puzzling. For example, here, I mean, I would think that, for example, in the UK, this might be more due if it happens because of people are really dissatisfied with their jobs. But could be the same case there? Is it because of low wages, for example?
Yeah, low wages are not a problem for nurses in California. One factor, I think there are two factors. I think one is that the process of kind of onboarding and doing the initial on-the-job training of a nurse after their graduation can be expensive and time-consuming. And so employers, I think a lot of them hope that some other hospital will do that, and then they can hire them later, right? So you have that kind of cost of that first 2 years. And I think that causes a problem. In fact, I've even seen and heard that in some union contracts that hospitals are required in the contract to hire or to have additional staffing if they have more new graduates in order to not overwork the older nurses or the incumbent nurses. I think those things create an incentive for hospitals to pay a higher wage to try to find an experienced nurse. And then we're finding that new graduates are going to other states, and then sometimes they come back after they have experience. And it varies, we're in rural states and some regions of the country, I don't think there's the same problem. But we have very heavy unionization and high wages, and also a very lean hospital system with relatively low reimbursements for them. So I think that makes a big difference.
Thank you very much.
Yeah, it's kind of crazy, right?
Yeah, relating to that question, I know there's a fraction of nurses move out of the state, but there may be also inflow happening, right? People graduating somewhere else, moving to California too, right? So do you know the net inflow or is the net outflow in the end? I mean, people are going to move regardless of whatever you do, because for family reasons or other reasons. So that there's some people are bound to be not going to stay where they, born and raised and studied, right? So we can't assume that everybody can retain one particular zone unless, no matter how good it is. So there's going to be natural inflow and outflow will happen. But if it's a large outflow, then we might kind of see, okay, if the incentives are not aligned or not, right?
Yeah. It's, the inflows and outflows are fairly balanced overall. California used to be a major importer of nurses, both internationally and from other states. And over the past 10 or 15 years, it's been pretty balanced. But we are losing younger nurses, and then we'll get back some older nurses. And of course, all of this overlooks differences in the regions in California. If you take California and you flipped it over and laid it on the eastern part of the United States, you cover about 8 states. And so we have some very rural regions that may have shortages all the time, and then some urban areas that have a lot of nurses who graduate and then have to move out of the area to find a job. So it's, which I think is a worldwide phenomenon with urban or rural differences. And, we could say for any country, this is the average, but then what's happening in a small town is different than what's happening in London, or what's happening in Milan is probably quite different than what's happening in a smaller village in southern Italy.
Thank you. Anybody has any other question? I don't see. Okay, so thank you everyone for an excellent session on the workforce related issues. And thanks for all the participants and the questions asked. I hope we had a good time, and sorry for those who stayed awake late in the evening or night. But this is the last session, so have a wonderful break now. Okay, thanks everyone. Bye-bye.